We have 24 people in the meeting so far. And I've started recording.
Should we give it just a few more minutes?
Yeah, some people are still joining, maybe like 1 more minute. I would start pretty soon though.
Hey, Jessica, do you want to pause the recording or stop the recording for now? And then once it starts, you can.
All right, we're up to 29 participants. Oh, make that 30. And I've resumed the recording.
Perfect. Thank you, Jessica. Good morning, everyone. Thank you for joining us this morning. We are going to hear a presentation from John McElfresh, who is the Oral Health Workforce Coordinator, and so much more within the oral health world at OHA. He's going to give us a presentation on the evaluation of organ health plan dental provider enrollment. And I know we do have several committee members on the line with us today to hear the presentation. And I'm happy that we have so many people here, John, to listen to this. So I will go ahead and turn it over to you.
Sounds good. Thanks, Laura. Always nice to be introduced by someone who's worked with me for several years running now. And I want to thank everybody for being here today for the opportunity to discuss our evaluation of Oregon Health Plan dental provider enrollment. As Laura mentioned, my name is John McElfresh, and I am the Oral Health Workforce Coordinator in the Clinical Supports Integration and Workforce Unit. Now, this evaluation is really the culmination of many months of work to analyze the barriers to expanding the number of providers who accept Oregon Health Plan patients and develop some recommendation on how to mitigate some of those barriers. So, give you a brief outline of what we'll be talking about today. First off, we'll start with some background on the HRSA Oral Health Workforce Grant, which funded the generation of this report and largely dictated where we did our data analysis and did interviews with some interested parties. Then we'll move on to why we did this evaluation. Why did we decide to allocate resources for the generation of this report? Next, we'll talk about the report methodology we used to generate the report. Then move on to Oregon Health Plan, dental provider enrollment barriers, and facilitators. Lastly, we'll end with some recommendations to try to mitigate some of those barriers. And then we'll have a questions and comment period for committee members to contribute to. And in my mind, this is the most important part of the presentation, is to get your various perspectives and your subject matter expertise on the report so that we can be informed on how we might be able to better tailor the report to make it more informative, or, some possible details on things we may have omitted. So next slide, please. So some background. As I mentioned, the HRSA Oral Health Workforce Grant funded the generation of this report. Now, the grant itself is a 4-year grant for $1.6 million, which is allocated over a 4-year period, which is awarded to OHA in 2022. This was to develop and implement innovative programs addressing dental workforce needs in specifically targeted areas that have populations experiencing health inequities, or dental HIPSAs. The grant's purpose is to expand oral health access and create more equitable dental health services, specifically in Douglas, Jackson, Josephine, and Lane counties. Now, we do this in a number of different ways. First off, we work with Capital Dental Care to augment their existing mobile dental van project in Lane County. Grant funds are used to subsidize costs associated with the recruitment and retention of additional providers for the project, and to provide incentives to patients so they show up to their appointments, thereby mitigating some of the no-show rates. Secondly, we work with OHSU School of Dental Public Health to host a series of annual didactic sessions for current and potential preceptors throughout the state of Oregon. Via the Echo platform, we host these didactic sessions. So the purpose of these didactic sessions is really to improve the efficacy of dental operations while clinics host student clinical rotations in rural areas. Now, the didactic sessions topic touch base on things like how to give and receive feedback from students, how to maintain the capacity of their clinic while hosting these student clinical rotations, and how to effectively onboard the students. Third, we recently released a request for grant proposal for organizations to apply for grant funds so they can create or augment existing teledentistry programs to expand access in Josephine County. Lastly, we work with our grant evaluation staff at the Oregon Clinical and Translational Research Institute, or OAKTRE, to analyze the efficacy of the various grant projects and lead the analysis and drafting of reports such as this one. Now, despite these concerted innovative efforts to expand access to oral health care, we still have some noticeable gaps in access across the state. Next slide, please. So why do this evaluation? One of the primary reasons is most Oregon counties have a shortage of dental providers. Now, as evidenced by the map, 33 of Oregon's 36 counties are currently designated as dental health professional shortage areas, or HCWFs. Now, health professional shortage areas use federal methodologies to determine areas in Oregon experiencing a shortage of providers in different healthcare disciplines, including oral health. Now, dental HCWFs are scored by a number of factors. Now, the one caveat with scoring a dental HCWF as opposed to a primary care HCWF or behavioral health HCWF is the availability of fluoridated water. So as most on this webinar probably know, only 22% of Oregonians have access to fluoridated water currently, which is well below the national average of 77%. So another factor involved with this is the distance to the nearest provider. Typically, we take a town or community within a service area for dental HCWF and assess the average distance to the nearest provider who's providing Medicaid services. Another huge factor involved with this is the local population's poverty level, the percentage of the county typically that's underneath the federal poverty threshold. Now, another factor that can be involved with this is the prevalence of certain populations experiencing health inequities, such as homeless populations or migrant seasonal farm workers. And lastly is the population to provider ratio, which is probably the most relevant to this presentation. Next slide, please. So dental provider network adequacy. Inadequacies in Oregon's dental provider network are mainly attributable to two factors. One is a maldistribution of dental providers. Now, the large urban areas such as Eugene, Salem, and Portland are largely inundated with dental providers. And our data analysis over the past few years has led to conclude that this is attributable to a few different factors. In 2021 and 2022, working in conjunction with OHSU School of Dental Public Health faculty, we developed a survey tool which was sent out to fourth-year dental students who had recently completed their student clinical rotations and asked them to assess factors that would incentivize them to relocate the area to render services. Now, some of the most heavily weighted factors were things like spousal satisfaction, the proximity to an urban or community center, and the availability of recreational social opportunities. Unfortunately, when we asked students to weigh or assess whether the area where they completed their student clinical rotation possessed these same attributes, the mean scores were rather low. Another factor involved with dental provider network inadequacy is the lack of dental providers who accept Medicaid patients in many areas. Now, based on our 2023 Medicaid claims data, only 27% of dental providers throughout Oregon filed a Medicaid claim in the year 2023. Furthermore, only 12% of providers throughout the state of Oregon actually filed over the threshold of 600 Medicaid claims in 1 year. suggesting that a small fraction of Oregon's dentists are handling the bulk of oral health care for over 1 million patients on the Oregon Health Plan. This obviously creates capacity issues and causes long wait times for OHP patients to access care. So using data from our DHS Medicaid claims team and OHA's healthcare workforce reporting program, we were able to ascertain several factors involved with dental providers' full-time equivalents, or FTEs, which is equal to a dentist filing 4,000 claims in 1 year. So 32 of Oregon's 36 counties currently lack adequate dental FTE to provide services to Medicaid members. Now, as evidenced by the map here, the different shades of blue indicate the higher level of dental FTE to meet the federal metric requirement for network adequacy, which is 1 Medicaid provider for every 5,000 residents. So as you can see, there are 8 counties, which are largely rural, which require over 3 dental FTE to meet this requirement. Now, this can be especially problematic for rural counties because they typically have more problems with recruiting and retaining providers. And another thing you can see is that another data point that we figured out using the Healthcare Workforce Reporting Program data is that 18 counties throughout Oregon have a higher population to provider ratio for Medicaid patients than the population to provider ratio for serving commercial insurance patients. Next slide, please. So the report methodology, key informant interviews. Interviews were conducted with OHA staff engaged in the provider enrollment and reimbursement processes, as well as prominent members of Oregon's oral health system. Now, the processes outlined by OHA staff for reimbursement and enrollment process were fairly straightforward and clear. Unfortunately, this narrative ran counter to the experiences described by dental practices, which will be explained in a later slide. Interviews conducted with prominent members of Oregon's oral health system, which included high-ranking members of Oregon's DCOs and clinic administrators at some of the state's largest federally qualified health centers, focused broadly on efforts to expand oral health access throughout the state and communications around OHP. These interviews highlighted the innovative ways that some of these organizations are working to expand oral health access, including the use of teledentistry and the integration of services into primary care clinics. They also underscored the complex nature of oral health care throughout Oregon, including the difficulties that are associated with integrating dental services into a primary care clinic, barriers patients have to retaining care, and the political landscape that largely influences the amount of resources that are allocated towards providing oral health services. Another reoccurring theme that we found during the course of these interviews was all the providers and clinic administrators and members of DCOs emphasized the need to appeal to the altruistic nature of dental providers while combining this while making serving Medicaid members financially viable. Next slide, please. So another aspect of the report methodology was interviewing private practice dental clinics, including dental providers at the clinics and clinic administrators, and the HRSA Oral Health Workforce Grants targeted areas, again, including Douglas, Jackson, Josephine, and Lane County. And these interviews touch base on things like the practice background, which included things like their current staffing levels. Did they have any noticeable gap in their current staffing as far as licensed dentists or some of the auxiliary providers like dental hygienists and dental assistants? We also touch base on things like their current catchment area, the demographics of the patient base that they're currently serving, what their facility is like, how many dental operatories do they possess, or are they associated with a primary care or behavioral health facility? We also touch base on their status of OHP enrollment. So if respondents answered yes to this question, we touch base on things like how long had they accepted OHP patients, or their overall experience with filing Medicaid claims, their future plans for accepting Oregon Health Plan patients, And what would make accepting OHP patients a lot easier? Now, if the respondents answered no to these questions, we touch base on whether or not they had accepted OHP in the past and specific reasons they had for not currently accepting OHP patients. And also the biggest barriers to, excuse me, serving OHP patients, and what are some of the things that could alleviate these barriers? Next slide, please. So during the course of these interviews, we identified some reoccurring themes as far as challenges facing dental practices. Obviously, the recruitment and retention of providers, especially for small clinics that are located in rural and frontier areas, can be especially problematic, which is attributable to a few different factors. Among these is the competitive pay among private practice dental clinics, a lack of qualified candidates to fill the vacant positions, which would indicate a shortage of oral health providers throughout the state. Also, a substantial number of auxiliary staff like dental assistants and dental hygienists who left the workforce altogether during the COVID-19 pandemic and have not since re-entered the workforce. Another challenge that they had mentioned were the managerial burdens that restrict capacity. Now, practices often cited the tedious nature of filing Medicaid claims, especially if they were working with multiple payers, and that these types of processes took time away from providing care to their patients. Another thing that they repeatedly mentioned was the tedious nature of trying to meet some of the metrics set forth by OHA and the various CCOs that they work with. And the last thing, one of the main challenges that was consistently identified was insufficient reimbursement rates for dental services. Providing routine dental services can often be one of the most expensive types of basic healthcare services, causing a lot of clinics to be in the red, so to speak. Now, this is exacerbated by the fact that dental providers having experienced large pay increase since the onset of the COVID-19 pandemic. Now, multiple providers also stated the need to increase reimbursement, especially for specialty services like periodontal services. Next slide, please. So some of the barriers that dental providers experience as far as enrolling into OHP. First thing would be poor communications around changes in covered services. Often providers were not aware in a change in the covered services until they had filed a Medicaid claim and the claim was denied. Obviously, this makes it difficult to render care for patients, especially for those that are suffering from acute oral health issues. Unclear enrollment process for clinics. Many of the providers were unclear about the process for becoming an OHA provider that accepts OHP patients and the process that's involved with becoming a contracted provider with the various DCOs and CCOs. Now, this can be especially problematic in some of the service areas that have more than one CCO present. They also cited the administrative burden that's involved with accepting OHP patients. Many of the providers cited the need to fill out extensive templates to file a Medicaid claim and to complete thorough chart notes to get pre-authorizations approved. Now, many of the providers also said that they weren't aware that they needed these things until a claim was denied again. So for smaller practices, this administrative burden can be especially problematic, given that they often don't have administrative staff dedicated to filing claims and figuring out the reimbursement processes. Another factor involved with this is the constraint in covered services. So fluctuations in covered services can obviously cause a lot of confusion among dental clinics. For example, many providers mentioned that there were exceptions for providing periodontal services during the COVID-19 pandemic, but ended when the state of emergency expired. Other things they mentioned is that OHP typically doesn't cover many surgical procedures like the removal of wisdom teeth, which is a common issue. Also, that OHP patients are only allowed things like one pair of denture every 4 years, which can be problematic because dentures sometimes don't correctly mold to the contours of the mouth, which can cause discomfort for patients. Another thing that exacerbates this issue is that the fluctuations in timeline for getting pre-authorizations approved. Sometimes pre-authorizations were approved very quickly, other times they can take up to 4 weeks. And providers also shared their opinions that OHP population has a higher no-show rate and requires more complex care compared to patients that are on commercial insurance. All right, thanks. So some of the OHP dental provider enrollment facilitators. So integrating into a primary care clinic makes providing dental care financially viable. Oftentimes, dental clinics are in the red while primary care clinics are in the black. This can offset costs and facilitate the enrollment of dental clinics into OHP by allowing to expand their capacity. Another enrollment facilitator is that large practices often benefit from economies of scale. Now, large practices often have a dedicated staff specializing in filing Medicaid claims and getting pre-authorizations approved. Large practices also typically have the resources to dedicate to provide robust incentive packages for providers to incentivize them to retain their services in rural and frontier areas. So lastly, we'll end with a set of recommendations to mitigate some of these barriers. So lower effort strategies. We define lower effort strategies as those that don't require substantive policy changes or a high level of coordination between educational institutions or organizations that are providing oral health services throughout the state. So direct outreach to dentists and improved communication. None of the providers we spoke to indicated that they had been directly contacted about OHA, about accepting OHP, which indicates a gap in proactive engagement. Now, key informant interviews stated that before the COVID-19 pandemic, there was a dedicated staff person at OHA to train dentists in OHP and reimbursement processes and enrollment. However, their perception is that that position no longer exists. So implementing a communication and outreach plan to reach providers may reduce misconceptions about OHP and provide a point of contact to facilitate participation in the program. And clarify and standardize provider enrollment processes. While OHA staff outline a pretty clear process for enrollment into the program, the engagement between DCOs and CCOs and private practices needs to be streamlined and made more transparent. Interviewees reported conflicting narratives about how DCOs and CCOs and private practices coordinate treatment of OHP patients and determine reimbursement. Standardization will reduce administrative burden and facilitate participation in OHP. So, higher effort strategies. Higher effort strategies are typically defined as those that may require substantive policy changes and a high level of coordination sometimes between educational institutions, OHA, and organizations that are providing oral health services. So the most common thing that we encountered during these interviews was inadequate reimbursement rates. So obviously increasing reimbursement rates would improve or alleviate some of the financial pressures that dental clinics are experiencing throughout the state. Many providers stated that although they do not accept OHP patients currently, they would be more incentivized to do so if they can make it financially viable. Now, improving loan repayment incentives. So several private practice dentists that we spoke to stated that their main motivation behind opening a private practice clinic was the substantial student debt that they incurred while going through their education. Now, improving communication about student loan repayment incentives could possibly expanding eligibility to different provider types would likely increase this among dentists, increase interest among dentists. So also having a robust funding package for loan repayment incentives that's dedicated strictly towards oral health providers could increase recruitment and retention rates throughout rural and frontier areas in Oregon. Another higher effort strategy would be to address workforce constraints. So improvements to expand the oral health workforce could alleviate the pressures that many dental clinics feel throughout the state as far as gaps in their workforce and redress constraints for caring for more patients. Now, addressing these broader shortage of oral health providers involves increasing training programs and providing more opportunities for provider types like dental therapists and expanded practice dental hygienists. Educational institutions could also make a concerted effort to recruit students from rural areas, which would increase the likelihood that they would retain their services in rural areas once they were licensed. Another recommendation is to provide funding to subsidize the costs for students going through oral health training programs, thereby increasing the number of students who are enrolled in educational programs. Several educational institutions have reported directly to me that they have experienced a decrease in enrollment in the last several years, especially for dental assistant training programs. And the last higher effort strategy would be to add covered services, including services that providers deem necessary would align financial incentives with professional judgment and mitigate concerns that OHP patients are receiving a substandard level of care. Next slide, please. Okay, and that's it. So questions, comments, concerns?
Thanks, John. I think the one thing that there was a lot of things about this presentation that struck me as interesting. One of the things that could we go back, and I don't know which slide it's on, sorry. The slide where you talked about wisdom teeth and covered services.
That wasn't on the slide, but.
Oh, it wasn't? Okay. I think the one thing that I just want to point out is, you know, I think sometimes communication can be a little challenging, but with the benefits, because I know wisdom teeth are a covered service, but then there's criteria that are involved with the wisdom teeth being covered. So I just don't want people to have the misconception that they're not covered. But again, there's criteria for the wisdom teeth being covered by Oregon Health Plan for being extracted. And Elena, I see I can't see everybody, but I see you. So, you know, feel free to jump in. But I see that as a barrier. And I think you probably mentioned communication, but I just see that as a barrier sometimes, you know, the lack of knowledge with some of the providers not knowing, you know, if you're doing a pre-authorization for wisdom teeth to be extracted, there are criteria that need to be met before that pre-auth is going to be approved.
Yeah, absolutely. No, thanks for that feedback, Laura. And this is the perception of the dental providers that we interviewed. Many of them thought that the removal of wisdom teeth wasn't covered. So that's a good tidbit to know going forward.
Yeah, and I'll just tack on to that. Hi, everyone. I'm a dentist, so I get to be on the other side of the sending the pre-auth. And yeah, it definitely, like, I would say it took me 3 or 4 years. I'm in my 6th year of working in an FQHC and taking care of patients who have OHP. And it took me probably 3 or 4 years to like really understand the OARs and understand those prerequisites. And I can see like that can be then getting patients to understand that also, to be like, okay, your wisdom teeth need to come out. It won't be covered until you have severe pain or infection. So like we can pay to have them out preventatively, or we can wait until they hurt you or have a big cavity. That can be sort of a delicate conversation to have with patients. So I can imagine that that's one small example that can lead to the confusion or sort of the disenchantment with some of the OAR coverage. Now, a lot of it is very generous and very, like, in Oregon, we have generally a very broad coverage for our Medicaid. And I think that as I talk to new dentists and dentists that know that they want to work in public health or know that they want to work in an FQHC or have a NHSC scholarship, I tell them, I'm like, look at the scope of Medicaid coverage in the state where you're going to be practicing. That's going to influence your experience as a dentist. In Oregon, we're really lucky that most things that I'm going to recommend for disease prevention and disease treatment are going to be covered. And that is not true in every state. So I think there are two sides to that coin. We have a pretty broad coverage in Oregon, and there are still some loopholes and complexities that it takes some time to understand.
Yeah, absolutely. No, thanks for that feedback, Elena. Now, if it took you 3 or 4 years working at La Clinica, which is one of the most effective and knowledgeable FQHCs in the state, I can imagine how long these processes would take to learn for a smaller private practice in a rural area. So,
John,
Well,
first, thank you for a really informative presentation. I'm curious, you mentioned that the providers had brought up a need for a more robust workforce. Did they make any suggestions or give any feedback that we could actionalize to actually move that forward? Did you get any feedback in that way?
yeah, I mean, a few of them mentioned to provide funding packages to educational institutions to start new programs related to the training of dental hygienists. As many on this call know, starting a hygiene program at a school is one of the most expensive programs to operationalize. That's why a lot of schools aren't involved with it. So that was definitely one of the recommendations they had.
All right, thank you.
Can I just say one thing, and then I'm sorry I have to hop off this call, but you know, one of the things that has always amazed me about medical and clearly dental school is that there isn't enough information given to entering medical students about the National Health Service Corps scholarship programs. And I think putting some effort into that would really help, because you know, when we have a wonderful FQHC in Madras with a great dental suite that has never been able to attract a dentist, which is a terrible use of funds, and you know, they need one. So I think if there were more dental students that were in the scholars program, it would likely go a long way to fulfilling those highest need areas. I don't know. I'm making the analogy with medical school, so I'm not sure that it works exactly the same way, but just guess.
Yeah, no, I think that's a very good point, Rob. Fortunately, in the state of Oregon, we have also a pretty robust incentive program called the Healthcare Provider Incentive Program, which is administered by one of my colleagues on my team. And while it's very similar to an HSC program and the Scholars Program, it does have additional eligibility for additional providers. So, you know, working in conjunction with federal incentives and state incentives, I think, yeah, can go a long way towards those efforts.
And John, I'll double emphasize the work that you've been doing with preceptors and supporting preceptors, because that is, anecdotally, we have fourth year students come to the Clinica in Medford, and Medford's kind of in that like not quite rural, but not really urban setting. And so we sort of bridge, I think we have feet in beat in both areas. And I think like you said, the experience that students have on those rotations, even if they're not super impressed by the city, if they have a really positive experience with their provider, it might sway them to at least consider working in an FQHC or working in public health as their first job out of dental school. So I think that's another, as the workforce committee, as opportunities come up to support preceptors and support training and recruitment of preceptors for fourth year external rotations. I think that is just something to keep our ears tuned to as well.
Yeah, absolutely. And I think dental organizations' perceptions of clinical rotations is a very important facet of that. I've talked to some FQHCs, including yours, where students are a value add to the clinic, whereas others, it's, you know, they're wondering how they can maintain capacity while hosting these student clinical rotations. So, you know, I think reducing the level of perception among dental clinics that this can be a good thing would go a long way to improving how many students are doing rotations in rural areas. Can't see everybody, but
Are
Any
there any
other-
more questions for John? You had a couple, there was a couple things in chat, John, I noticed.
can't see the chat, but thank you, Laura.
Yeah.
I can't
Alma,
see the chat. I do not see any hands up.
Alma spoke to maybe hearing more about Elena's experience with the FQHC. And then Sean Ramsey Watson just want to share how Mercy Medical Center added an EPDH to provide preventative care to our patients. The program is wholly embraced by medical staff and patients. Are there any thoughts of expanding this type of initiative? Our hygienist is connecting OHP patients to care and helps cut through the red tape. We are also now in the process of being able to receive reimbursement. Sean, is that in the hospital setting itself or in a primary care clinic? Hospital? Okay.
I'm assuming that question was directed to me. Yeah, I mean, the various DCOs, Capital Dental and Advantage Dental, have pretty robust teledentistry programs that involve EPDHs that render services. I've heard on a few occasions that integrating an expanded practice dental hygienist presents some problems when integrating into a hospital, or is more cumbersome to actually operationalize that. But I know that certain organizations are working to do similar things around the state.
And then Alma, I'm not sure if I answered your question already. I'll send you my email address directly if you want to follow up. But my experience in an FQHC, so I had an NHSC, not the scholarship, but the Students to Service program. So I had a commitment to work in a FQHC after dental school. I did 1 year of a residency after dental school, and then came to La Clinica, which is where I've been for the last 6.5 years. And it's been a largely positive experience. We have an awesome group of dentists. There's 8 dentists in my building and then 2 others at another site. And so you asked about resources or education provided internally. We don't have any formal education programs, but there's a lot of natural mentorship and case, you know, I've got a second and a third and a fourth and a 7th opinion built in because of my work site. We also have structured study clubs every month, and La Clinica does an awesome job of providing some sort of leadership and development opportunities through an internal training program called the Learning Well. So that's a bit about my experience. If you have specific questions, I'm happy to chat with you via email.
Hey, Aletta, thank you so much. I apologize, I'm on the road, everyone. But I was really gauging more of like the educational resources to understand the claim process, prior authorizations around the dental and oral services. I really always want to gain more insight on that, and if there's something that OHA can do to provide more material or supports directly. A lot of the information that we have is very outdated, very old, you know, even old recordings of how to access our claim system and everything. So it's really wanting to hear if there's something OHA can do better on that level. I heard some really great suggestions that were shared earlier about like the compensation incentives, which is great for that recruitment and compensation piece of it, but really the sustainability and knowledge piece I feel is still missing when we have new providers who are joining these clinics. I know there's a lot of internal practices and mentorships, but is there something that OHA can do to complement all those efforts? Because I feel like that some of that responsibility should be on us as an agency to provide, I'd say, more education upon joining clinics and navigating and understanding. It is a big administrative burden on some of those smaller practices, I serve Southeast Oregon, so we're very rural. I work with Grant Hardy County, so a lot of the dentists that are practicing here don't have those internal practices and support. So I always like to gauge a little bit more and understand experiences from different dentists, and if there are any infrastructures or something that we as an agency should maybe be looking at a little bit more for rural frontier counties and even those that are in between, like where you're at.
I love that idea. My education has largely been that we have a billing department and a dental billing specialist that has been with La Clinica for 15 years. So she taught me everything I know. And so that obviously is not a replicable or scalable model across the state. So I'd love to hear it. John, do you have any responses or thoughts about that?
No, I do know that some of my colleagues here at OHA and DHS have made some efforts to do outreach to dentists across the state involving processes for reimbursement and getting pre-authorizations approved. I can certainly bring this to the table at our next OHA oral health meeting and see about developing a more robust plan as far as doing outreach to dental organizations. Because obviously we identified, during the course of the development of this report, there are gaps, and you're reiterating that point. So obviously more that we can do.
Thank you, John. And I'm more than happy to chat offline too. I'm with OHA CPOP team. So the experience that I see is slightly different than some other parts of the state. So always happy to chime in and share some of the things I'm hearing from our dental providers here.
Absolutely. That sounds good. If you want to put your email in the chat, we can confer offline.
Any other questions or comments for John or anyone? I don't see any hands. Okay, John, I will leave it to you to close us out.
Okay. Well, again, just want to thank everybody, committee members and members of the public for their participation. And yeah, that's all I have today. So have a good day, everybody.
Perfect. Thanks everyone for joining us.